Mark Student. And I'd like to thank Cairo Secure for giving me the platform to share this information with. I'm usually very excited to be in this venue and share, but today is just incredibly special for me because I really get to attack a lot of different subjects that are germane and timely to our profession. So let's go right to the slides and let's get started. We have a lot to cover today. We're going to talk today about initial chiropractic treatment plans and frequency protocols. So, 3 times a week, twice a week, once a week, daily, 12 visits. What's my initial treatment plan? Well, it's not quite as simple as that, but there are rules, and it is quite as simple as that. But before we get to the treatment plans, we have to understand that we have to look at a definitive diagnosis. Now, today we're going to discuss issues related to pain. We're not going to talk about what people call maintenance care or wellness care or ongoing care. We're going to talk about pain because that's the common denominator in every chiropractic practice in the country. That is the absolute common denominator. Everyone treats a patient with pain. So when you have the patient, in your office, you have to initially triage. You have to create a diagnosis, then a prognosis, then a treatment plan, which must be reflected in your documentation before you treat the patient. Now, a diagnosis is an identification of a disease via examination, or let's word pathology, whether it be connective tissue pathology, which is ligaments and muscles, strain, sprain, whether it's osseous pathology. These are the things we need to figure out first. So remember, then you get to the prognosis. Following the diagnosis, it's the prediction of its course and then treatment. Can I get the patient well? And I have to know that before I come up with a treatment plan. Or the treatment plan, let me rephrase that. You have to do the prognosis, which then ends up into your treatment plan. And if you can't help them, your treatment plan might be referral to a surgeon, referral to this, referral to that. That's your treatment plan before you treat. And before you treat is the critical answer. You have to know what you are treating. And I have to tell you, in my formative years, I would just adjust patients and just adjust them and not know any different. And you know what? I got in trouble for that. It cost me dearly. And I did have problems. So let me share with you Mark Student's mantra, which I've been saying since 2006. If you don't know, don't guess. If you don't know, don't guess. I've had this conversation with doctors through the years. Doctor, a patient's coming in and they come to me and they say, patient has radiating pain down their arm. And by the way, I teach in 3 different chiropractic colleges at various levels and 2 medical schools at various levels. And I'm giving you what's an academic standard. I'm giving you licensure board standards. I'm giving you carrier standards. And I'm giving you a patient-centered standard. And patient-centered treatment comes from, actually it's called the best practice treatment, comes from Sackett up in Canada back in the late 90s. 3 things: the evidence in the literature, the doctor's experience, and the patient's feedback. So you ready? Here it is. If you don't know, don't guess. Just don't guess. And doctors often come to me and say, I have patients with pain radiating down their arm. What'd you do? I adjusted them. What are you treating? The pain radiating down their arm. No. What's causing the pain radiating down the arm? What are you treating? Subluxation. Okay. How do you know that? Because that pain radiating down the arm. No, you keep going back to the symptom. What's the cause? Or I'll say or they'll say spinous rotation or vertebral rotation if they don't like to use the word subluxation. Okay, or biomechanical failure. I don't care what the word is. What are you treating? What's causing the pain? What component, if you're using the word subluxation, is it myopathology, histopathology, kinesiopathology, pathophysiology, histopathology? Which one of those things are causing that? And by the way, those 5 segments of subluxation complex are from Leonard Fay, who's still alive out in LA. I spoke to Leonard a few weeks ago, and we owe all of him a tremendous debt of gratitude. But I want you to know it was all hypotheses. It's all hypotheses. Leonard had no definitive answers when he came up with that, but as time moved on, the evidence in the literature started to show that. So at the end of the day, I said, how do you know what's there? And the answer is, and we went in circles: pain, subluxation; pain, biomechanical failure; pain, rotation. How do you know if you don't look? Have you taken an x-ray? Is there an osseous misalignment? Is there a spondylolisthesis if it's in the lumbar spine? Is it a tumor? Is it a herniated disc? You don't know. You're guessing. You don't know. And if you don't know, you don't touch. Simple. Don't know, don't touch. Because the answer is that if you do, you can hurt somebody. And you know what? Not knowing, putting a bag over your head, hurts all of us. It hurts the reputation of chiropractic. I work with hundreds and hundreds and hundreds of neurosurgeons, orthopedic surgeons, pain management doctors, ER doctors from coast to coast. I teach, I've taught them in 39 different states, something like that. And every single time they say, they came from the chiropractor and now the person has a herniated disc, which I don't believe to be totally true. I think there was an underlying problem, which the chiropractor didn't diagnose and then exacerbated. So that's my personal belief, and I don't have a specific case to bring out. But they'll say they went to the chiropractor, it didn't work. The person had a tumor. The person had a myelopathy. The person had this. Why didn't they diagnose it before they treated? And it hurts our reputation. And reputation drives referrals, folks. Reputation drives referrals, and never forget that. You want to get more referrals, increase your reputation. A dear friend of mine is a marketing consultant for orthodontists, and he's probably one of the most successful in the country at it. He's in an airplane. He's in a different city, presenting, teaching. He teaches up at Tufts University Dental School in Boston. Guy's incredible. You know what? You know what his entire business is about? Building the reputation of an orthodontist. Build it to the general dentist, build it to the public, because those are the referral sources. Well, guess what? Our utilization is stuck at 7%. Some people say 10. I think that's inflammatory. We've been stuck there since I've been in the game since 1981. I'm in my 42nd year of doing this stuff. We're stuck at that same level of utilization. So what I've done is I've worked with academia to build collaborative requirements between chiropractic and medical academia. And right now, we put in about 1,600,000 additional referrals into chiropractic practices in 49 states. So the answer is, I know it works. I watch it work. I watch it every day work in different offices. But what happens is when you guess and someone gets hurt, or they don't get better and you don't have a definitive diagnosis, and they go to the ortho, neurosurgeon, pain management doctor, urgent care clinic, primary care, guess who it hurts? Not just you, it hurts everybody. And you know what? You should never, ever, 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 ever treat someone without knowing what the cause is. Simple. Hard rule. So we have two kinds of pain. Pain with radiation. Now, that can be caused by a myelopathic finding or radicular pain, where you have arms, legs, flanks, the chest, intermittent lancinating, electric or burning, again, which can cause that. Radiculopathy, if you have motor weakness, sensory weakness, paresthesia, diminished reflexes, worse with axial loading. Well, what's causing all of those things? What's causing it to radiate? I know I can get them well. I'm going to adjust. I know I can get them well. I'm going to put a genie rub on them. I'm going to do joint mobs. I'm going to put E-stim. None of those things are going to help, by the way. They're going to help them feel better temporarily. It's not going to get to the cause of the problem, especially if you don't know what it is. But then you can have the second kind of pain without radiation. None of these things going on. Zip, nada, zilch, gunish, niet, no matter what language you put it in here, you have localized pain. Just localized. So if you're having localized pain without radiation or pain with radiation and these things occurring, well, why? It goes back to what I said before. If you don't know, don't guess. You need a definitive diagnosis. And by the way, what does that have to do with initial treatment plans? The answer is everything. Everything. Because your treatment plan has to be legally defensible. Because if it's not, it could cost you your money, your license, or your freedom. And I've seen doctors lose all three. You know what happens when you get in trouble? Well, how many doctors do you know that have been taken down for a RICO case or have been charged with even a criminal charge by hurting someone, by causing significant issues? Probably nobody. I know a lot of people. If you were sued for RICO, who would you tell? Nobody. Zero. You'll only tell them when you saw 40 new patients last month, and you probably lied about that also. I'm the father confessor. Mark, what do I do? How do I get out of trouble? I have one standard answer. Call a criminal defense lawyer. That's my answer. I told someone that just yesterday. They called me Christmas morning. They were served the day before. What do I do? What do I do? Call a criminal defense lawyer. It's the only answer. And I hear it all too often. Not because you're necessarily hurting someone, you might be delaying necessary care. You might have have a pathology that went undiagnosed. You are responsible for all of that. And it's not a question to practice out of fear. Just follow the rules. If you don't know, don't guess. Diagnosis first, prognosis second, treatment plan third. Simple, simple, simple. So therefore, no matter what you've got going on, the commonality of treatment within chiropractic is a high velocity, low amplitude thrust, a chiropractic spinal adjustment. That's what all of us are taught, and hopefully all of us are doing. I don't care if you're doing physical therapy, what we call adjunctive therapy, joint mobilizations, arthrokinematic movements, heat, stim, laser, this. I don't care what you're doing, okay? But if you're doing a high velocity, low amplitude thrust, a chiropractic spinal adjustment, and if I had time, I would go through again, which I've done in the past, the mechanism of the chiropractic adjustment. It's fascinating. It's all in the evidence, all in the literature. It has to do with the brain and central sensitization, which I'm not going to get into right now. But if this is what you're doing, you've got to be careful. You've got to be careful and make sure you do it right. And by the way, I didn't put a reference, and from here forward, we're going to start to see a lot of references. I didn't reference the fact that the wrong vector can be dangerous to the human spine. The wrong vector of thrust is critical. Remember in school we did posiology? You go inferior to superior, superior to inferior, left to right, right. All those things are important. All those things you've learned are critical. So here's what most everyone relies on: palpation, motion or static palpation. And that's an issue. Why? Well, let's read right from the evidence in the literature. Palpatory tests studied, regardless of the studied condition, demonstrated low reliability and were invalid or unreliable. By the way, you're going to see me turning this way. I'm working on multiple screens. I'm reading off the other side because that's my mouse's. And should not be used to arrive at a diagnosis, treatment plan, or assess progress. Motion palpation is poor. It's failed for inter and intra-rater reliability. It's not my opinion. It's right from the evidence in the literature, and there's a lot more studies than this. There's a lot. So if you're looking at, so here's the next one. I look at range of motion. Well, you know what, folks? Range of motion is a problem. You want to know why range of motion is a problem? Because you're looking for hypomobility. Hypomobility is not the problem. Hypermobility is the problem. Hypomobility is usually muscle spasticity. Unless you have osseous fusion or an osseous locking mechanism based upon an anomaly, which happens rarely, the majority of your motion palpation showing decreased range of motion, number one, is muscle spasticity. Number two, it's global. You're looking at C1 through T1 in the cervical spine. I've got a cervical up here. You're looking at the whole motion, and it could say 45 degrees normal inflection. What if you have fusion at C5-6 and it still shows normal inflection 45 degrees? That means the other segments have moved too much to compensate for the one moving too little, showing normal, but yet you're calling that a normal study. And how could you have normal when one segment is fused? One motor unit, two bones is fused. How could you have that? You can't. It's not possible. The issue is too much movement. That's the problem. And not globally, segmentally, because that means the connective tissue is torn. The ligaments have torn. You have connective tissue pathology. And when you have a ligament that tears, according to Hauser, which I don't have up on the screen today, according to Hauser et al., once tissue tears, it wound repairs, it doesn't heal, it wound repairs with a different grade of tissue. So studies have shown that once tissues have damaged, they remain, and that's right from the evidence in the literature. They remain non-functional for the rest of that person's life because collagen and elastin in the ligament are only replaced with collagen because you have the fibroblasts in the ligaments, which during puberty, they're producing more collagen and elastin, the ligament's growing. When you hit puberty and it stops, those fibroblasts become dormant. They don't go away. Those dormant fibroblasts stay there until there's tissue damage. And when there's tissue damage, now you only have collagen. There's no longer elastin. And even a spinal disc, which is a ligament that connects bone to bone, is, I believe, 95%. No, I apologize. It's 75% collagen, 25% elastin. Where an elbow, and I don't have the exact number, but for academic purposes, I'll say 50-50 collagen and elastin. But now, when a joint has more collagen replacing elastin, the joint starts to adhese. Now, you would think it would adhese and decrease the range of motion. No. The tissue tore, literally tore. It's a secondary strain sprain. Primary is overstretching, fibers pop. Secondary is partial tear. Tertiary is avulsion. We don't get the avulsions. We'll get primary, mostly secondary. So when you have that secondary strain sprain, it's going to leave a healing gap. And now that's going to fill in with collagen. It's not going to knit tight together and like stitching it together. No, it's going to fill in that healing gap and lay down collagen. And it's going to wound repair. I'm not going to use the word heal because healing implies it's going back to normal tissue. It wound repairs with internal adhesions, permanently giving excess space or excess range of motion. And therein lies a specific problem. That's an issue with range of motion. You should be looking for too much. You can't tell this when you look at palpation, either motion or static. But you see, chiropractic is safe. According to Whedon et al. In 2015, they studied 6,669,603 test subjects. And it shows, and by the way, that accounted for 24 million visits, no mechanism by which a spinal manipulation and chiropractic adjustment induces injury into normal tissue has been identified. Zero zippity doodah. None. But herein lies another problem. Normal, healthy tissue. Injured spine versus healthy spine. How many people come to you with a healthy spine versus an injured spine? Most people come to you with injured spines, and they're not a healthy spine. If it was healthy, why would they be in pain? Why would they have dysfunction or functional losses? Why? Well, we know that it's relatively safe in a healthy spine, but you have to identify that injured spine. And therein lies the issue. How do you do that? Well, let's look at diagnosing an anatomical versus biomechanical pathology. And what does this have to do, by the way, with treatment plans? Everything. We're leading up to that in a moment. Everything. Now, let's look at anatomical, which is on your left side. You could choose unwisely, which is one of our political organizations, pick that up from the American Board of Internal Medicine, which is a dangerous place to be and creates a public health risk. And I mean that sincerely, because they only want you to image for red flags: fracture, tumor, infection. That's it. Fracture, tumor, infection. Now, they got that from the American Board of Internal Medicine providers, who, based upon the evidence in the literature, I think out of Harvard, failed to they diagnosed non-specific back pain, approximately 95% of the time. Non-specific means there's no anatomical cause. They don't know what to do with it. They have no clue. And they failed, I think it was a 75% failing rate in competency in musculoskeletal medicine. So here you are, people creating a profound platform with no success in spine, no education in spine, coming up with a policy, and then our political organization has chose to follow that. Now, I want you to know right now, Blue Cross Blue Shield across the country is trying to limit your ability to take x-rays in the first 28 days of care. And I don't have the facts yet. I hopefully will soon. And I think this program, Choose Unwisely, as I call it, might be the genesis for that, to the detriment of our patients and our practitioners. But then again, we want to look at an anatomical and biomechanical pathological diagnoses. You're ruling out fracture, tumor, infection, connective tissue pathology, ligaments, you can do that through imaging, and biomechanical pathology. You know what you're treating, you are not guessing. Let's look at some of the issues. You ready? This was incidental anatomical pathology found in offices in the last 3 months of this recording, because I just put it out there. Look at this spondy. Can you imagine putting this person in a side posture? This person had mild cervical pain. He's got a clay shovelist fracture. This guy can't be treated in your office, and I wouldn't want to adjust until this. I mean, does it really have any sequela on the rest of the spine? Probably not, but I don't want to be treating someone with a fracture. Look at these mets all over the spine. They're all over the place. And I saw the CAT scan. It's a lot worse than this. But this, look at these lucencies in here. This is all mets from, I think this person had kidney cancer. I don't want to treat this patient. Can you imagine putting them on their side? And look at this. This is Paget's disease. This person had minimal low back pain. And look at this one. This is Eagle syndrome. Calcification, I believe it's the hyoid bone. I'm not going to do a rotary on this person in this cervical spine. Look here, secondary, okay? The thyroid and the hyoid. This is all calcifications. These are not normal findings. This grossly changes my diagnosis, prognosis, and treatment plan, which is only a small portion of what I'm looking to do. Now, there is technology out there. One such piece of technology is called Simverta, which will take a spine, and instead of motion palpating, it'll give you a roadmap of which way the spinous processes are rotating, and it's 100% correct every single time. The evidence in the literature is overwhelming, and I forgot to put that citation up here. And it'll also tell you to adjust superior to inferior, inferior to superior, and it will give you other issues such as angular deviation, translation. We don't really have time to get in this, but what you're doing is you're getting a roadmap. There's no guessing. But let's look at the additional benefits of doing an x-ray to come up with a definitive diagnosis. You're going to get paid, because now the carriers are going to say, what are you treating? Well, I'm treating this, which is now demonstrable. This is pathobiomechanics. It's biomechanically pathological, and there's an ICD for biomechanical pathology. You can also get paid for long-term care because you can repeat an x-ray. Now let's take the radiation issue off the table very quickly. And this is according to Tubiana. I didn't cite the reference for this. Tubiana said that you need 100 millisieverts of x-ray, of radiation, in one sitting, because it's not cumulative, to have less than 1 in 100,000 negative, to have less than 1 in 100,000 disease process show up from radiation. Or radiation, 1 in 100,000. So to get to the 1 in 100,000, you need to take 56.6 lumbar x-rays at one sitting. You need to take 100 thoracic x-rays and 5,000 cervical x-rays in one sitting to reach that number. And that's kind of absurd. No one's going to take a 5,000 cervical x-rays or 56 lumbar x-rays in any given sitting, and radiation is not cumulative. So the sky isn't falling, folks, and this is all over, it's evidenced all over the literature. But you can get paid for long-term care to show the persistence of these lesions. And what we're starting to see in lawsuits, in RICO suits across the country, is the carriers are going after doctors for predetermined treatment plans based upon range of motion, muscle testing, Well, they've got an answer for that too. There's no answer, and I'm told formally, there's no answer for this. This is proof positive. So it does a whole lot of things. It tells you where to adjust, when you've reached MMI, get paid for long-term care, and it prevents lawsuits because it makes it demonstrative. And there's a lot of things out there you could use. Even an x-ray that you're marking up yourself will do the trick. The other thing you need to learn from an x-ray is ADI, atlantodental instability. This Civerta does that also. But if it's 3 millimeters or more, it's unstable. And this is very unstable, this patient. This was a patient done 2 days before this recording. So 3 millimeters is unstable, and you should strongly consider altering your treatment plan. If you've got an instability with the ADI joint, the ADI interval, you got the atlantodental or the transverse ligament up there. You've got perhaps a myriad of other ligaments in that area, ligament of nuchae, a bunch of other things that you've got to be concerned about. You might want to alter your treatment plan significantly. Don't be doing a cervical or especially an upper cervical adjustment, and you might possibly want to co-manage that with an MD specialist. You know, the doctor who did this sent it right out to a neurosurgeon, and the neurosurgeon said, you know, you're the only chiropractor that ever did this and that ever referred to me and recognized it. Most adjust and then hurt the patient. They end up coming to me after. You're the guy I want to work with. And he started sending him, well, he just sent this out 2 days ago, but he said, I'm going to start sending you a lot of cases because you're the guy I want to work with, because it's evident, it's demonstrable, it's evidence-based, and you're working with, you're collaborating, and you're working within the healthcare system. You're not fighting it. You're working with it. And guess what? They see 99% of the patients. We see 7%. You want to keep fighting for 70, you want to tap into that 99. And this is through a posture of clinical excellence. No advertising, no marketing, no fancy dinners, no holiday gifts, only because you're a damn good doctor. And you've understood diagnosis first, prognosis second, treatment plan third, then treatment. Initial treatment plan, get a co-manage with an MD specialist, and get a surgical consultation. Does this person need surgery? Probably not. But you know what? I want a written clearance from the surgeon saying not chiropractic is indicated because he has no experience in chiropractic. I want him to say conservative care is clinically indicated. That protects my butt. It protects my patient, builds relationships. It's good for chiropractic. And we go all the way back to the beginning. You know, we're going to go all the way back. Here we go. Right there. That's where we're going. The band comes off the head, the Band-Aids come off, and all of a sudden, everyone's getting referrals. And that, to me, folks, is what it's about. Let's look at chiropractic as primary spine care providers versus medical management. Well, according to Dayton et al., over 96% of chiropractic patients with spine-related problems stated they were healthy. Compare with these statistics to medicine, which persisted about 95% diagnosing non-specific low back pain. So here we are helping 96% of the people. They're helping only 5%. They're only diagnosing 5%, which is the fracture tumor infection. They don't know what to do with the rest. So you want to build that reputation in the relationship because we're helping these people. When we look at evolving protocols, and evolving protocols are key. As the evidence evolved in every healing discipline, so do treatment protocols, with large enough cohorts, a cohort is a sample size, to further confirm the efficacy of care. In determining the necessity of initial x-rays, the American College of Radiology, that is the holy grail in medicine to determine imaging, all imaging, CAT scan, x-ray, MRI, PET scan, tomograms, whatever it is, they're the industry standard and the gold standard for everyone. It says they had deemed initial imaging of radiograph of the spine with or without radiculopathy, it says usually appropriate, which is their strongest recommendation, removing any controversy on standard of care. You have medicine putting it back in at a high level when our political organizations who are supposed to be protecting you are working hard against you to take it out. It's absurd. But now we go to the next step about treatment. Let's talk about treatment frequencies. And by the way, this is something I teach in chiropractic academia in the classroom. This is something I teach as a clinical instructor for the State University of New York at Buffalo, Jacobs School of Medicine and Biomedical Sciences, Office of Continuing Medical Education. I have to put that whole thing in there. That I'm teaching around the country for medical education, and I'm teaching chiropractors this, and I'm teaching medical doctors this. Because not to be chiropractors, to how to refer to a medical doctor. And it's long, and I'm going to read it, so bear with me. Whalen et al. Reported that an appropriate standard of care is multimodal treatment, inclusive of a chiropractic spinal adjustment and manipulation for 3 times per week for 4 weeks in the acute and chronic patient. Treatment may be initially provided more frequently and tapered as the patient improves. So that's a chiropractic spinal adjustment, multimodal in the beginning. Heat, stim, laser, Therex, whatever you need to do. Continuing treatment should be predicated on the demonstration of improvement in functional capacity and not only a temporary reduction in complaints. They have to get back to function. A small population of patients with chronic pain with more complex problems may require ongoing care after a plateau in subjective and functional status has been reached. Patients with severe pain scale 7 to 10, and don't give me a scale of 1 to 10, it's 0 to 10. And it's the visual analog scale. Go to Mr. Google, print out the visual analog scale picture of the smiley faces, laminate it, put it on every wall in your office to refer to. That will protect your butt. Patients with severe pain greater than 7 out of 10 and findings consistent with moderate to severe functional limitations may warrant daily treatment for up to a week to manage pain and improve function. Hey, I did that when I practiced. I'm going to see you every day for the first week. They're acute. You can only do a little over a long period of time. Go home and ice it. Patients with more complex presentations, significant comorbidities, chronic neck-associated disorders, or whiplash-associated disorders might require longer periods to demonstrate subjective, objective, or functional improvement. That's a protocol, folks, and this is your reference. 3 times a week is not 12 visits. I don't know where the heck, I'm going to see you for 12 visits, Mrs. Jones. No. It's 3 times a week for 4 weeks and then a reevaluation. It's not 12 visits. That could be 3 months. How do you know how many visits it's going to take? You don't have a Ouija board or a crystal ball. It's 3 times a week and then a reevaluation. You want to see them daily and then 3 times a week? That's fine. You want to see them twice a week? That's fine. But in 4 weeks, you're doing a reevaluation. Non-negotiable. This is a legally defensible posture, and it will help your patient. I don't have time to get into why 3 times a week is important from a physiological perspective of how you're retraining the muscles, the ligaments, the tendon. You're working with central sensitization with Pacinian corpuscles, your crimp receptors, your Affini corpuscles, your stretch receptors, your Golgi tendon organs, which are also, those are all mechanoreceptors, and the nociceptors, the free nerve endings, which pick up the environment around those joints. All of those are mechanoreceptors and some proprioceptors, which feed into the lateral horn, up the spinal thalamic tract, through the periaqueductal gray area, into the thalamus, ping-pongs around the brain, goes efferently off into disparate areas for compensation, and helps your body. It takes time to do that while you're creating biomechanical homeostasis. There's the answer and the reasons, but 3 times a week is not 12 visits. So, folks, I think that takes us to the end of our time. I really enjoyed putting this together. It's taken me about 12 years to put this information together. I had a whole different program, and 2 hours before this, I said, I don't want to do this. I wanted to do this. It was just needed in the industry, and it's needed by you. So again, I'd like to thank ChiroSecure for giving me the platform to sharing this information, and I look so forward to doing this with you the next time we do it in a few months, and we'll just keep doing it, and we'll hit every subject, hopefully, that are hot button issues in our profession to help you practice better, help more patients, and enjoy. Thank you so much. Have a great day.